My name is Kevin Kopis, and I am the Program and Outreach Manager for the Epilepsy Foundation Northwest. Thank you all for coming. This is, I believe, our 7th annual conference honoring the month of November, which is Epilepsy Awareness Month. I want to start by introducing our new Executive Director, Sharon Cupp. Is right there. So Sharon is, I think, in her first full month with us. So she's still meeting people. So if you haven't met her already, please introduce yourself to her. So Sharon can start getting more connected with our organization. We're really excited to have her on board. So thank you, Sharon.
Thank you, everyone.
And I also want to thank the sponsors that have helped underwrite the cost of this conference. They are all located out in the lobby. Looks like I saw lots of you guys talking to them. Great people with lots of good information to share, and they all have a interest in epilepsy, so please do spend some time with them. We will take breaks throughout the day and then a lunch period, and so they'll still be around, so please do talk with them. And as far as kind of structure of the day, we have these little free-floating mics that we will pass around. At the end of the speaker's presentation, you all have an opportunity to ask questions. So we'll do it kind of Oprah Winfrey style and pass microphones around to you, and you can ask them questions. And then if you know someone that wanted to be here but couldn't, my friend Joe back there in Seattle's IT department is recording all of these presentations. So they will be available on our YouTube page, all of the presenters. Give me like a week or so to get them up there, but feel free to pass them on to people who, again, couldn't have been here that want to see the presentations, so just know that they'll be available. And then, what else here? If there are school nurses here, I saw a handful of them coming in. Is Lisa Huggins here?
No, Lisa's not. I'm Lynn, and I'm taking over for her today.
All right, thank you, Lynn. So Lynn is here to vouch for the hours, because the nurses do get clock hours, so I want to make sure there she is. See her about getting that stuff. Just another note on the nurses. There's some of these presentations you'll see today are part of a grant that we got, and in accordance with the grant, we have to have pre and post surveys completed. So the school nurses have those surveys, so you may see some paper shuffling as we kind of collect those surveys. So that's what that's all about. Not that we're excluding anyone, it's just for the school nurses. And then I guess with that, I will turn things over to Dr. Novotny. And Dr. Novotny is the head of the epilepsy program here at Children's Hospital. He is on both our governing board and chairs our professional advisory board, so we're very lucky to have him connected with our organization. And thank you, Dr. Bronson.
All right, thanks everybody for coming. This is a great time. I think this is a great time when it comes to epilepsy for many different reasons. People may have heard that in August of this year, the CDC actually came out with a new epidemiological study. How common is epilepsy? And actually, epilepsy is the increased prevalence over the last decade or so. So actually, almost 3.5 million people now have epilepsy, but we're and over almost 500,000 of those people are children. And so I think it's really important. We're at a wonderful age now with genomics, a lot of technology, a lot of advances in things that are really going to change our way that we're treating epilepsy and making diagnosis of what are the underlying causes. And I hope that you'll hear a nice broad group of presentations from here. I think we've actually chosen this program based on feedback from previous programs. I think we have a quite diverse group of speakers that are going to give different points of view, different aspects when it comes to epilepsy. And the other thing I think for people to be aware of, actually, just this year, 2017, a group called the International League Against Epilepsy only took 10 years for them to identify what the new classification of epilepsy is, and better defining what are the underlying types. There's over 40 types of seizures and epilepsy syndromes. And they've really made it so it's a little more user-friendly than some of the old terminology. But I think it's really important that actually the whole world is becoming more aware of it, and there's really more of a need to understand not only the epilepsy and the seizures that occur, but with an emphasis on this new classification are the associated problems that happen when both a family and a patient has epilepsy. It's not only the seizures, there's a broader range of problems, and I think some of those issues are going to be addressed at this meeting, this conference. What I also want to give a round of applause to our volunteers here on the Epilepsy Foundation. Kevin has been unbelievable in helping organize this, and Jessica Veach and Sharon as our new executive director of the Epilepsy Foundation Northwest. And I just want to acknowledge their work as well. So. So from that, I think we'll move on, and I think Mrs. Billy Collins is going to introduce our first speaker.
Good morning. My name is Billy Collins, and I'm a mom of a 16-year-old daughter with epilepsy. Our first speaker this morning is Dr. Kevin Joseph. Dr. Kevin is a medical director of Pediatric Neurology. He's board certified in epilepsy and sleep medicine at Valley Medical Center, Neuroscience Center Institute in Renton, where he's been practicing since 2010. Dr. Joseph went to medical school, Kansas City University of Medicine and Biosciences. He completed his residency and fellowship training at Walter Reed Army Medical Center and the Children National Naval Medical Center in Washington, D.C. He quickly followed a deployment to Iraq from 2007 to 2008, and after returning from Iraq, he was stationed at Madigan Army Medical Center until 2010. While at Madigan, he was chief of child neurology and assistant program director of the neurology residency. Dr. Joseph is a huge supporter of the Epilepsy Foundation as he serves on the Physician Advisory Board. He encourages each and every child that comes through his clinic starting at about March that it's time to start signing up for camp in the spring. My daughter has been a patient of his since 2013 when she was diagnosed with epilepsy. I thought to myself, a few medications and we would be good to go. I thought we would see him every 6 months or so and life would be lovely again. Little did I ever imagine that my daughter would have multiple medications and multiple levels of those medications, not to even mention all of the side effects associated with all of the different medications. So after a few years, we opted for a VNS, and then we would have some more fun in our future. It was while we were waiting for that VNS surgery day to arrive that I needed to administer some rescue medications. And I could not get that medication to work. I had a major mom fail moment. I called Dr. Joseph's office with complete distress and tears. Within minutes, doctor called me back. Obviously, a little too late now, but I told him what had happened. He reassured me that I was okay and I really wasn't alone. He said, bring it to you to the day of surgery and I will teach you how to use it. Surgery day came and Dr. Joseph did show me how to use that medication. I said to him, maybe someday you could teach a class. I'm not the only one in this situation. He said, maybe. I told him, maybe will come, doctor. So I guess my maybe, he said, is happening today as he is here to talk about using rescue medications. So really, doctor, I appreciate everything you've done for my daughter.
Well, welcome. So we're going to talk about emergency medication or rescue medications for seizures. I'm going to dive a little bit deeper, more deeply than perhaps you've heard before or than we would do in the clinic. Hopefully it'll be interesting. So this is our clinic. You know, we have a lot of fun there. We have a Halloween party every year. There's my office with the hippo. I've got the hippo room. There's some patients, and we also do this purple pumpkin thing every year. So next. There's our costumes. That's my son. He's a ninja, and actually that's me and my partner, Dr. Judy Lee. So that was just a couple weeks ago. So status epilepticus is a term for a prolonged seizure. This is a description of a woman having a seizure in 1766. So I kind of like to think that she's been in status epilepticus for many, many years. So today we're going to talk about what status epilepticus is. We're going to discuss emergency medications, review some of the medicines, and how to administer them. So status epilepticus is, the definition is basically it's a single seizure or multiple seizures that without return to baseline function lasting 5 or more minutes. You may have seen other definitions. Those are sort of for research purposes where it's 30 or more minutes. That's a really long time. But 5 or more minutes is the relevant definition for us. The longer the seizure lasts, the less likely it is to stop on its own. And this is an emergency. So beyond 5 minutes, seizures will potentially, there's a risk that it will harm brain cells. There's decreased oxygen. There's formation of lactic acidosis or lactic acid. So there's lactic acidosis because there's not enough oxygen, and the cells revert to a less efficient form of producing energy that produces lactic acid as a byproduct, and that's toxic for the cells. There's not enough sugar. The pressure inside the head will start to increase. And there's also systemic results. For example, your muscle, the muscle enzyme, muscle will break down. That releases muscle enzyme into the blood, and that could potentially clog up the system, particularly the kidneys. So what do you do when someone is having a seizure, when your child is having a seizure? First thing, check your watch, support their head, try to put them on, lay them on their side, preferably their left side. That's considered the lateral recumbent position. Don't put anything in their mouths. This is from the Epilepsy Foundation. This is a good depiction of what to do. I suspect that in the event that your child's having a seizure, there will not be 5 or 6 people laying around. It may just be you and one other person. So once the watch shows 5 minutes, most likely you'll call 911. If you have a rescue medication, you'll use it. So what are the choices? So for rescue treatments, this is not an exhaustive list, but generally these are the options: midazolam, diazepam, lorazepam, and if your child has a vagus nerve stimulator, there's a magnet. So, there you go. And you can get really nice responds for them. So how do these medications work? The goal of these seizure medicines are to reverse the hyperexcitable activity of the brain cells, of the neurons. You want to reduce that excitability, so you want to cause some inhibition and you want to reduce the excitation. You may have heard of 2 neurotransmitters, GABA and glutamate. Gamma aminobutyric acid and glutamate. GABA is a very potent inhibitor, and glutamate is a very potent excitatory neurotransmitter. So what most of the seizure medications do is increase the proportion of GABA and decrease, which hopefully will decrease excitation. And they do this by altering electrolyte channels: sodium, calcium, potassium. Benzodiazepines, those are midazolam, lorazepam, diazepam. Those 3 medicines are in the category of benzodiazepines. So benzos will quiet down the neurons by making the GABA channel open more frequently and allow a chloride ion into the cell to help calm things down. So There's actually some really great cartoons online. I suppose I probably could have put them in the talk. So maybe next year. There's the GABA receptor. That's outside the cell, that's inside the cell. And that is your benzodiazepine, midazolam, diazepam, lorazepam. It comes in, boop, clicks in to that little spot there. And this neurotransmitter GABA comes in and clicks in on that spot. And then it causes the GABA receptor to open more frequently and allow chloride to flow into the cell and quiet things down. So let's get back to the medications. There's key questions that we need to ask to help decide which medication would be best and to understand how they work. So how fast does the medication work? How long does it last? How is it given? Who can give it? And how much does it cost? So lorazepam is the mainstay of first-line medication used to stop a seizure. It's very effective, stops seizures within a couple of minutes. It lasts 6 to 12 hours. It sticks around in the brain a really long time. We can be given intravenously, intramuscularly, but only licensed healthcare providers can give it. It is inexpensive. This is most likely what's going to be used in hospital. Diazepam, it also is very effective. It can stop seizures within a couple of minutes, sometimes a little bit longer. Doesn't last nearly as long in the central nervous system as lorazepam because it's very quickly distributed or sucked up by fat throughout the body, and that ends up pulling it out of the brain. It can be given many ways, intramuscularly or rectal, IV as well. Anyone can give it. This is the only drug of the ones that are available to treat seizures that is FDA approved for use by everyone. So you don't have to be a licensed healthcare provider to give diazepam. The formulation that most people are aware of or familiar with, is Diastat. It's a rectal diazepam. It's very expensive, $371. This is from a source I found a few years ago, but it's probably about the same. Generic is not much cheaper. So it's expensive, although if you think about it, this hopefully will avoid calling 911, having an expensive ambulance and emergency room visit. So if you look at it, and which also often includes a head CT and all kinds of things. So that's clearly more expensive than giving the Diastat. How is this medication, or how are these intranasal and rectal medications, how are they absorbed? They're absorbed through blood vessels in the mucosa. This tissue in your nose, actually I can use there's the buccal mucosa, which is in your cheek, and the nasal mucosa here, very highly vascularized. There's a lot of blood vessels in there, and they suck up that medication. So it's a really great, very effective way to get the medication in your body quickly. There's the Diastat. This is I think this is not a real one, so, but it doesn't have medication in it, So there's the sample. Have you all seen this famous or infamous depiction of how to give the medication? If you have a child seizing, you go grab the kit, you pull the Diastat out, you take off the cap, and you put them in the left lateral recumbent position, and you administer the medication. So I think this makes it look a lot simpler than probably it really is when you have a child who is seizing, vomiting, looking like they're going to die, not turning blue. You're panicking. It may be the worst moment of your life, and they're not just laying still. So but this is this is certainly one approach. Midazolam is another option. It's also a benzodiazepine. Stops seizures within a couple of minutes. Lasts 3 to 4 hours, so it lasts longer than the diastat. Not quite as long as lorazepam. You can give it intranasally. You can give it buccal, which means in the cheek, in the mouth. Intramuscularly, intravenously. It's relatively inexpensive. There's the cost of the medication, and there's the cost of the MAD, which I'll talk about in a second. Anyone can give it, but it's not FDA approved quite yet, and it's not marketed. It's not being formally produced by pharmaceutical companies yet. So midazolam can be injected through. That's what you would be using right there. I took some photos from an excellent handout of instructions that Seattle Children's put together to help guide people through giving intranasal midazolam. There's the MAD, the mucosal atomizing device. So that's the MAD right there, the little spritzer. So it's great to have this handout, and it's really important to walk through it, hopefully beforehand a couple times, because again, if your child's having a seizure, your mind is not really working well. It's very stressful. And there's a lot of steps here. So you pull out this syringe. It's got this needleless plastic system. You pull the liquid out of the vial. It's vacuum packed, so you gotta push some air into it first, and then you can pull the liquid out. You quickly swap out the plastic needle, and you put the MAD on the mucosal atomizing device on, and you pull up, make sure you have the right amount of liquid, and then you spray approximately half of it into each nostril. So what are the pros and cons of buccal versus and intranasal routes? Well, easy access, fast acting. The buccal and intranasal routes, they don't pass through the liver on the way to the brain, as opposed to the rectal route, which gets rapidly absorbed through the vessels in the rectal mucosa, but it does pass through the liver, so that slows things down. Well, if your child is throwing up or drooling a lot, or if there's a lot of nasal discharge, that could clearly interfere with the administration of the medication. So for the rectal route, similar, easy access, sometimes not so easy access. If there's stool, that also clearly, and the stool could impair the absorption, and also, as I was mentioning before, this does pass through the liver before it gets to the brain, so that slows things down. So what do you do next? You've managed to put the medication together, administer it, and it works. Or the seizure stopped on its own. Either way, who cares, right? The seizure stops, because most seizures will stop on their own. It's important to keep in the back of your mind. Most likely you'll call 911, although in certain situations, and we can talk about that in the office, you don't necessarily have to call 911. But certainly if this is the first time you're giving it, call 911. And I always tell parents, if you have any questions or concerns in this situation, just call 911. It's okay. So in summary, status epilepticus is a seizure or cluster of seizures. They last 5 or more minutes without return to baseline mental status. you should consider using the medication if the seizure does not stop within 5 minutes. Lorazepam, diazepam, midazolam. Lorazepam can only be given by a licensed healthcare provider. Diazepam is the only FDA-approved medication for use by everybody to stop seizures. Intranasal midazolam is probably faster acting than rectal diazepam. I think in our community, intranasal midazolam is probably the #1 choice amongst the epilepsy doctors for use by their patients. In other communities, it's buccal midazolam, but I think that we'll be hopefully seeing, I think Dr. Nervati was telling me, hopefully within the next year, we'll be seeing this marketed and we can just prescribe it for you. And that'll be much simpler than having a vial of liquid and having this kit that you gotta put together. So here's just some resources, the Epilepsy Foundation and Child Neurology Foundation. I think that,
So let's say you do pay the $350 for the last 2 and you keep them in your home. What are we talking about in terms of expiration dates? Like, does it last, do I have to pay every year for one of these, or do I have to pay one every 5 years?
it's, I don't really remember. I think it's a year, yeah. It's about a year shelf life. Yeah.
I've got a question in terms of, it sounded like primarily you're focused on children who are having prolonged seizures. Are treatments and outcomes the same for adults? What are any differences there?
Yes, yeah, and I apologize. Every time I said kids, I realized that was not necessarily everybody in the room has a child with epilepsy. But yes, all this information applies to any adults and children. So I'm a pediatric neurologist, so I automatically, those words just come out of my mouth. So.
So I work as a school nurse, the 4 of us here do, and I'm confused about that everybody can give the lorazepam, because I thought in the state of Washington it was only midazolam that everyone is able to give, because that's a big situation actually currently in my job of who can give it for students riding on the bus with seizures and such. So I'm just a little confused about that.
So you mean the lorazepam? Well, lorazepam you have to be a licensed healthcare provider to. Diazepam, yes, is FDA approved. Is actually the only medication that's FDA approved for use by anyone, all lay people. So I think your question is that in the state of Washington, you're directed to only use midazolam and not. Yeah, that. I'm not sure. There's some political history to that, but absolutely in other parts of the country, it's been 15, 20 years, but I was in the Maryland, D.C. area, and school nurses were able to administer Diastat. But I don't know if
School nurses can, but not like her educator.
any layperson can administer Diastat. Right, but generally speaking, any layperson can administer Diastat. But in the state of Washington, I believe you're right that for some political reasons that I don't know the history behind, that you're directed to only be able to administer midazolam. Is that what you're saying?
I delegate midazolam. I can't delegate Diastat like her educator.
Yes.
Non-licensed.
Yes. Yeah. Does that answer your question?
Yeah.
So the Washington state law says that school nurses in the school setting can only delegate by certain routes, and rectal is not a route that we're allowed to delegate.
Okay.
So my question is, I have 2 questions. One is about lorazepam. Sometimes we see orders for buccal lorazepam in the school setting.
Buccal lorazepam?
Yep.
I'm not familiar with using it that way. I know that in some other parts of the world, and maybe in Europe that sometimes they're buccal lorazepam.
Renton.
Am I-
a dissolvable, what's called ODT,
Okay.
that is sometimes, that's actually more used in the adult
Mm.
sphere than in pediatrics.
That makes sense. We see it more in
Yeah.
the high school or adult transition
I understand now.
students.
So it's a dissolvable pill, yeah. And often if patients go through the emergency room with they're sent home with a lorazepam pill to use in it for emergencies. So yeah.
All right, and then my other question is, school nurses are not available every day in every school. And so, the orders that we get often say administer diazepam, or the Diastat or midazolam after 5 minutes. When there is no school nurse available to administer the Diastat, which unlicensed people in the school setting are not allowed to administer, is there a recommendation that still wait the 5 minutes to call 911 to then administer the Diastat, or should there be a different time to call 911 when there is no nurse that's going to be able to give the Diastat?
It's a really good question. Usually, what I tell parents and what I tell school nurses when they ask me is if someone has a seizure at school, and like you said, there's not a nurse who happens to be at the school at that moment, then just don't wait the 3 minutes. Just call 911.
Okay. And then my last question is, could you say more about the buccal midazolam and whether just more about that? That's a newish thing for me to hear.
Sure. Well, so the buccal midazolam and the intranasal midazolam, both are very fast acting and last a few hours. It's administered a little bit differently, so you don't use the mucosal atomizing device. Often it's just sprayed in through the syringe into the cheek area. And there's a lot of data to support using buccal midazolam to stop seizures. In children, I'm aware of. I'm not sure if there's adult data, but it is definitely an effective approach. In my practice, I tend to use the intranasal more often. I think, and again, this hasn't really been studied yet, but intuitively to me, it seems that the intranasal route is better. It's less likely to pour out, or you're not dealing with the teeth, because I really don't want people to be putting things in the mouth because it might get bitten off, including a syringe or a finger. So I think it's safer to just deal with the nose.
I had a quick question as well. I'm a school nurse with our group here.
Okay.
So all these rescue medications, are they primarily only for like the grand mal seizures? Or, because I'm having issues with that at school.
It's not just for grand mal, not just for generalized tonic-clonic seizures. It's for seizures that last more than 5 minutes, or a cluster of seizures, and that could be a myoclonic seizure. So someone could have several these myoclonic whole body jerks and their consciousness is impaired and it's happening frequently and not getting better. You could administer in that situation. Most likely it's going to be a generalized tonic-clonic seizure that this is being used for. Patients can have frequent absence seizures or staring seizures, and those can be very subtle. And I tend to discourage using the rescue medications in the school setting for suspected recurrent staring seizures.
And I guess timing of those kind of staring seizures, like if those are lasting over 5 minutes, is that a concern as well?
Yes. If they typically are very brief. They last seconds. So if it's lasting that period of time, 5 minutes, it's reasonable to administer the medication. Yeah.
Okay, thank you.
Hi, my son got diagnosed with epilepsy at 20, and now every once in a while, particularly in the last week, he had a couple of spacing out moments where he would say, "Mom, oh, I was just spacing out," and shake his head. How do you know that that's just spacing out, or it's an actual absent seizure or some other kind of seizure? And me as a parent, as a provider, how do I prevent or assess that or start monitoring that or do something to prevent? Because what happened on Wednesday, he had his grand mal seizure. And I'm starting to realize and think that maybe those absent seizures were actually his aura to let us know that something was going to happen. So
Yeah.
we're here to learn.
I mean, it's difficult to know. Sometimes it's almost impossible to be looking at somebody and know, are they spacing out, are they deep in thought, or are they having a seizure? And I totally understand your question. It's very stressful to know that, or to wonder if he's having lots of absent seizures, and those are sort of building up and evolve into a generalized tonic-clonic seizure. And often sometimes the best approach would be to put an EEG on him and have a camera on there. So do it, in other words, emit for a video EEG and really be able to discern, are these spells seizures? Are they not seizures? Is there any way we can pick out features that tip us off? If not, then maybe just know over a period of time how often is this happening, and then make some adjustments to the regular medications.
I have a daughter who's now 23, and she was diagnosed with epilepsy at age 9. Recently, the last year, I'd like to say, we've been dealing with weekly and most recently daily seizures. And she's under the care of a neurologist. We've been seeing them regularly. And we're in the process of tweaking medication. So they're saying, expect the daily seizures. But it's happening multiple times during the day. And we've been giving lorazepam. So she's been taking it every day. I mean, is it okay, long-term, 1 milligram lorazepam daily?
Well, ideally, because remember that lorazepam lasts about 6 hours, sometimes 6 to 10 or 12 hours. So it's not covering her all day. Generally, I think this is what you're thinking too, is if some other adjustment to her long-term medications needs to be made, so that you don't have to be giving this rescue lorazepam every day. But that would be my main concern. I don't know if you're concerned about long-term side effects from lorazepam. Is definitely sedating. So we want to minimize that because it affects the quality of life, of course.
Thank you.
So my son has been with children since he was 5 years old. And I wanted to kind of let you know some of the nurses of the questions. I've dealt with schools, I've dealt with nurses and things like that. He has used the midazolam, he has used the lorazepam, okay? One of the things that we networked with was the emergency system, like a fire department that was close by. If the nurse couldn't be there, possibly that they could call 911 and they could transport somebody who was closer by at the fire department that's closer to the school. That was an option to us, just to kind of network that a little bit. The question I guess I have is that using those rescue medications is that he clusters. I have cluster seizures that will last for a period of a longer time. And it seems that the lorazepam will work probably the best because it does have that long duration to it. But I understand exactly what this family's talking about also, that they start increasing. And then what happens is that I've depleted the system, his system of trying to fight with the lorazepam. It's not working anymore. I've depleted it. So I've learned how to use it very sporadically, and it's worked, it's worked. I don't have another answer for that, but I just kind of wanted to network that a little bit.
So I have a question about Keppra, because it's not one of the medication on your list, and it's often prescribed for seizure as well. And usually parents don't, unless it's a 3-day emergency meds, we don't really give it to kids in the school. So can you talk more about what Keppra does and how they are used for seizure?
So Keppra in an emergency situation, or
No, just to treat seizure.
Well, Keppra is a great medication. Levetiracetam, it's probably the #1 medicine used to treat seizures in the U.S. And it has a different mechanism of action, and in fact, the mechanism is not entirely clear, but it does ultimately, like the other seizure medications, it will calm down the excitation, or it reduce the excitotoxicity and increase inhibition in the brain cells. It does come in IV form, so it can be used in status epilepticus to treat seizures. And it's very often used in the hospital setting as sort of a second or third phase of treating status epilepticus. In other words, if the initial medication approach that we talked about here doesn't work, then we go to another phase, and that Keppra is often used for that as well.
So just a quick question. What we see is a lot of respiratory depression when giving diastatin midazolam in a school setting. We're kind of curious, how concerned should we really be with respiratory depression? And should these students who have that, should they have an embu bag just for the school setting? So I know that's a kind of like a mixed bag, but how concerned should we be with the respiratory depression?
Well, I'm gonna try to rely on the scientific data rather than give you my experiential, my subjective-ish kind of thoughts about it. But the data suggests that we don't need to be that concerned about respiratory depression or decreasing or suppressing breathing in patients who are given these rescue medications. But the likelihood is actually fairly small that there's going to be a clinically significant suppression of their breathing that's going to cause hypoxemia decreased oxygen in the blood. But I understand the other part of your question is you're a nurse, a licensed healthcare provider, administering care to a child that you may or more likely or not don't know very well, and you're in the school setting. I think it's reasonable to have something there to help you support their breathing if you feel that it's necessary, yes.
Any other questions? Oh.
Could you talk a little more about rescue peel tablet medications? My doctor gave me lorazepam, 1 milligram, tablet. It seems counterintuitive as a rescue med.
Because you're swallowing the pill?
Yes.
I agree. How do I answer that? I agree with you. If you're swallowing a pill, even if it's a great medication that stops seizures, it goes through your stomach, it passes through your gastrointestinal system, ultimately, eventually gets absorbed or ends up in your blood supply, and it ends up in your brain. That seems like it takes a long time. Yes. Ideally, I would recommend intranasal liquid like the midazolam or diazepam to be used, or buccal liquid. Yeah. That would be my recommendation.
Any other questions? Here?
The medicines she said, if we add Topomet on the top of those two medicines, gabapentin and lorazepam, how about that?
Adding
Topomet,
topiramate,
yeah.
Topamax, and Topamax, gabapentin, and lorazepam for treating but not necessarily for treating an acute seizure. But
seizures, yeah. After brain surgeries.
Well, those are so Topamax is an excellent medication for seizures as well, but it's not an effective acute emergency medication for seizures. It's a capsule or a tablet. It has to be absorbed just passed through your gastrointestinal system, just like the oral lorazepam we're talking about. Yeah, but it's a very good drug.
Yeah, actually the seizures are under control, but they were after the brain surgeries. So maybe that's the reason doctor gave that to me. It's under control now.
Oh, great. That's wonderful.
Thank you.
Sure.
Anyone else?
I can probably yell out now.
Okay.
I just was going to comment on Dr. Joseph mentioned seizure clusters, and I think most providers would promote giving rescue medication if there's back-to-back seizures without interval recovery. Even if they what looks like a normal focal seizure, people don't recover after or in between these events. That's usually an indication to administer a rescue medication.
Well, thank you for your time. Thanks for all the excellent questions.